Small bowel cancers don't occur often. The small intestine is actually the least common site in the GI tract for a primary malignancy. But when they do, they have weird names and can do some weird stuff. We're talking neuroendocrine level weird, with names like carcinoid and effects like serotonin syndrome. In that vein, we've set this sketch in the sewers, the perfectly weird home for the adolescent modified taekwondo lizards. Let's start things off with a bang. Carcinoid tumors, which are weird tumors that can produce a very unique set of weird symptoms. First, a little backstory. No one really knows where the adolescent modified taekwondo lizards came from. Maybe it was the radioactive ooze that was dumped into the sewer. Some say they don't exist at all. Just some kind of bizarre neon apparition, manifesting itself from an unhealthy combination of vanilla ice CDs and an unwarranted late 80s, early 90s nostalgia. Duh, look how cute. Whoa, bodacious. In this scene, carcinoid tumors will be represented by carcinoid canisters, which seem to be filled with some kind of mutagenic gooey stuff. So watch out. Carcinoid tumors arise from neuroendocrine cells, so we've drawn in a transformer in the back with wires running from it. Looks pretty neuronal to me. And as you'll soon see, these tumors like to release all kinds of hormone and neurotransmitter-like substances. While you may have heard of carcinoid tumors in other organ systems like the lungs and pancreas, the most common location for a carcinoid tumor is the small intestine. These tumors are called carcinoid because they grow more slowly than your average carcinoma. Don't be fooled, though. Just because they're slow growing doesn't mean they're harmless. As we'll see, carcinoid tumors can do some pretty funky stuff. Carcinoid tumors are most commonly found later in life, around 60 years of age, but can occur anytime. As mentioned before, carcinoid tumors are the most common form of small bowel cancer, with the ileum being the most common part of the small intestine affected. And if you take a look at the entire scene, you'll notice that the pipes on the left look kinda small intestine-y. And the big one on the right, your anatomical right, that is, looks kind of large intestine-y. So to remind you of the ileum specifically, the carcinoid canister is right there at the most distal part of the small intestine pipe. That said, carcinoid tumors can occur anywhere throughout the GI tract. You can find them in the colon or even way up in the stomach. In fact, around 30% of patients will have multiple lesions. So don't focus exclusively on the small intestines. Gotta watch where you step down here. Interestingly enough, carcinoid tumors are also the most common form of cancer in the appendix. So we've drawn in one of the carcinoid canisters on top of that appendiceal pipe sticking down from the start of the colon. Of course, carcinoid tumors aren't limited to the GI tract either. Where else have we heard the phrase neuroendocrine tumor before? That's right, the lungs. Like small cell lung cancer, carcinoid tumors can also affect the lungs, where they're called bronchial carcinoid tumors. In fact, the lungs are the second most common location for carcinoid tumors to occur, after the GI tract. Let's talk about bronchial carcinoid tumors for the briefest of moments, because carcinoid tumors of the lung are the most common type of primary lung cancer in children. These tumors typically present in late adolescence and are generally the same kind of low-grade, slow-growing neuroendocrine tumor that you'll find in the GI tract. Patients with bronchial carcinoids most commonly present with coughing, from irritation of the bronchi eliciting the cough reflex, as well as hemoptysis, from bleeding of the tumor into the bronchial lumen. Interestingly, carcinoid syndrome, a common component of gastrointestinal carcinoid tumors, which we'll dive into shortly, almost never occurs with bronchial carcinoids. So don't worry there, little guy. This neuroendocrine goo doesn't work on kids. Carcinoid tumors have a characteristic yellow appearance on gross pathology and are often surrounded by lots of fibrous connective tissue due to the intense desmoplastic reaction they elicit. On histology, carcinoid tumors are composed of islands of uniformly small, round, dark purple cells with scant cytoplasm. These islands of cells are surrounded by layers of light pink fibrous connective tissue. Pretty distinctive for a GI tumor. Zooming in even further, on electron microscopy, multiple dense granules can be seen in the cytoplasm of carcinoid cells. Kinda like this granular granite. These granules contain the secretory products and hormones that can produce the unique symptoms associated with carcinoid tumors, such as serotonin, histamine, and gastrin. Most carcinoid tumors of the small bowel are asymptomatic and found incidentally. If patients do present with symptoms, though, they most commonly have abdominal pain and intestinal obstruction. When carcinoid tumors latch onto that appendix, they can even cause appendicitis. So let's make that appendix pipe red and inflamed looking. As we'll explain in our large bowel disorder sketch, appendicitis is most commonly caused by something obstructing the appendiceal lumen. Usually, that something is fecalith, but a carcinoid tumor in the appendix can also do the trick. And when it does obstruct the appendix, the classic symptoms of appendicitis can result. Abdominal pain, first vague and periumbilical, then sharp and localized, along with anorexia, nausea, and vomiting. You might well think that this is pretty uncommon, but carcinoid tumors are actually the most common malignancy of the appendix. In fact, a carcinoid tumor is incidentally discovered on pathologic examination in 1 out of every 200 appendectomies. Now, I feel like I'm painting a poor picture of these modified Taekwondo dudes. They're just a bunch of totally rad, fun-loving reptiles that love pizza, and Big League Chew, and ring pops, as much as any 90s adolescent kid. Though, I must say, while GI carcinoid tumors are classically a laid-back, chillaxin, slow-growing bunch, they do have a predilection for metastasis, especially to the liver, hence the Taekwondo lizard here, climbing up to their secret liver base. This shouldn't be a surprise, as all that GI blood gets filtered through the liver first. We mentioned earlier that carcinoid tumors grow from neuroendocrine cells, which means they have the capacity to secrete lots of funky substances into the circulation and cause weird effects. Well, when carcinoid tumors are confined to the gut, these substances rarely produce symptoms because everything secreted by the tumor flows through the portal system and gets metabolized by the liver, much like the first-pass metabolism of oral medications. So, see that mutated histamine B? Nope, not today. And that smiley face serotonin pizza? The liver's gonna gobble that right up. Pizza time. Remember, at Sketchy, serotonin, the hormone that makes you happy, is always represented by a smiley face, like this one. All right, what if we metastasize beyond the GI tract? These guys just love to hang out in the liver, remember? Well, from here, all those hormones getting released are able to bypass first-pass metabolism and head directly to the systemic circulation. At this point, patients can develop what's called carcinoid syndrome. Although as many as 40 different vasoactive substances can be secreted by carcinoid tumors, the most common ones you'll see are serotonin and histamine, which exert some pretty gnarly effects. The most common symptom of carcinoid syndrome is episodic flushing, which usually occurs in the face, neck, and chest. Flushing is thought to be mediated by excessive histamine secretion. With prolonged carcinoid syndrome, chronic vasodilation caused by the release of these heinous vasoactive substances can lead to the development of vascular telangiectasias, mostly on the nose and cheeks. One of the most debilitating symptoms of carcinoid syndrome is secretory diarrhea mediated by excessive levels of serotonin stimulating intestinal motility. This can cause some patients to have as many 30 bowel movements per day. Bogus! Some with carcinoid syndrome may also have episodic bronchospasm and wheezing, as depicted by the wheezy party blower. It's important to differentiate carcinoid syndrome from bronchial asthma, however, because if you give a carcinoid patient a beta-2 agonist, the drug of choice for asthma exacerbations, you're just going to magnify all that vasodilation and cause profound hypotension. Also, you see those vegetations growing on the right-sided valves inside that heart-shaped chamber? One of the most interesting aspects of this serotonin-mediated syndrome is the development of cardiac valve lesions, which can occur in up to half of patients. Carcinoid valvular lesions appear as plaque-like deposits on the right-sided heart valves, i.e. the tricuspid and pulmonic valves. These little bumpy things are composed of fibrous tissue, smooth muscle cells, myofibroblasts, and an overlying endothelial cell covering. This occurs due to the stimulatory effect that serotonin has on fibroblast growth. So let's add in that smiley face. In early disease, there may be only mild to moderate regurgitation of the affected valve. More advanced fibrosis and valve dysfunction can lead to severe regurgitation and even valvular stenosis. Most non-triumphant. So, how come carcinoid syndrome exclusively affects the right side of the heart? Well, interestingly enough, the lungs actually serve to metabolize many of the vasoactive substances secreted by carcinoid tumors, including serotonin. Nom 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 nom. Therefore, by the time they reach the left side of the heart, there's no more serotonin to mess with the valves. The most common initial diagnostic test for carcinoid syndrome is measurement of 5-HIAA, short for 5-hydroxyindoleacetic acid, also abbreviated pulled my gracilis. 5-HIAA is a breakdown product of serotonin in the urine, so that's where you measure it. Yep, that's a waterfall of urine behind him. Just a minor blemish in an otherwise bitchin' underground sewer hideout. Party time! If the test is positive, the tumor can be localized with CT imaging or radionucleotide-labeled somatostatin scans, which detect the high levels of somatostatin receptors expressed by many carcinoid tumors. The treatment of choice for carcinoid tumors is surgical excision. However, due to the tumor's predilection for metastasis, removal can be difficult. In addition to surgery, somatostatin analogs such as octreotide are frequently used for symptomatic relief of carcinoid syndrome. Octreotide can bind to the somatostatin receptors on carcinoid tumors and inhibit the release of serotonin and other bioactive hormones produced by these tumors. Hear that, kids? Sometimes partying in moderation is cool too. That's our somatostatin stop sign in the back there, by the way. It even has 8 sides to remind you of the drug name octreotide. Shwing! And that's it for carcinoid tumors. Let's move on to a less common cancer of the small bowel, adenocarcinoma. Embodied in this scene by... Wait, could it be? No way, dude! It's Super Pincher, an evil, cancerous, mutated, crab guy. Also, you see all those bubbles? All glandy and stuff? This is to remind you of adenocarcinoma specifically, which usually shows glandular structures. While it was once the most common, adenocarcinoma of the small bowel has taken a back seat to carcinoid tumors. So we'll only discuss adenocarcinoma briefly here, with a much more detailed discussion in our colorectal cancer sketch. We've placed him in the more proximal small bowel segment because most small bowel adenocarcinomas are found in the duodenum, although many may present in the terminal ileum. But more on that in a moment. Like colorectal cancer, adenocarcinoma of the small bowel starts out as an adenomatous polyp. It's thought that the adenoma-carcinoma sequence is similar to that of the colon, but is less well characterized. Be sure to check out our colorectal cancer sketch for an exhaustive look at the adenoma-carcinoma sequence. First, let's take a quick look at the few familial conditions that increase the risk of small bowel cancer. While classically associated with colorectal cancer, both Lynch syndrome, also called HNPCC, and familial adenomatous polyposis, abbreviated FAP, dramatically increase the risk of small bowel adenocarcinoma as well. So send in the minions. FAP is embodied by this mighty morphin family of mutated polypoid shrooms. This inherited cancer syndrome is associated with multiple polyps of the duodenum and large intestine that undergo malignant transformation. Lynch syndrome involves messed up mismatch repair. No polyps this time, however. And as always, Lynch is represented by our totally freaky lynchworm, inchworm. Again, these syndromes will be covered in much more detail in our colorectal cancer sketch. And while we're on the subject of polyposis syndromes, let's talk about Peutz-Jeghers syndrome. Peutz-Jeghers shares many of the features of other large bowel familial syndromes. But this time, the polyps are largely localized to the small bowel. Every martial arts troupe needs a comic relief guy, of course. So let's meet our last adolescent modified Taekwondo lizard, PJ. His weapon of choice? The hammers. Meant to remind you that Peutz-Jeghers involves the development of multiple non-neoplastic hamartomas throughout the gut, but primarily centered in the small bowel. This occurs because of an autosomal dominant mutation in a tumor suppressor gene. So notice that we've incorporated our autosomal dominant domino design into each hammer. Hamartomas begin to form early in life and, while usually asymptomatic, can cause bowel obstruction, GI bleeding, or mesenteric ischemia. Since hamartomas are non-neoplastic polyps, one would think that the risk of cancer shouldn't be affected. However, patients with Peutz-Jeghers do have an increased risk of not only colorectal and small bowel malignancies, but extraintestinal malignancies as well, including breast, ovarian, and pancreatic cancers. Weird. One unique feature of Peutz-Jeghers is a mucocutaneous hyperpigmentation that affects around 95% of patients. The hyperpigmentation is caused by the accumulation of melanin-filled macrophages in the dermis, especially in the mouth, lips, palms, and genitalia. Just follow the trail of syrup coming off of that Peutz-Jeghers pop. Last but not least, Inflammatory bowel disease can also increase the risk of cancer throughout the GI tract, small bowel included. While ulcerative colitis confers an increased risk of colorectal cancer specifically, Crohn's disease, represented by those classic skip lesions and cobblestones, is associated with an increased risk of small bowel cancer as well. This tends to occur in the ileum, so we've focused our cobblestoning to the most distal segment of the small bowel sewer system. Crohn's disease affects the entire GI tract, but the abundant lymphoid tissue in the terminal ileum makes it the target for most of the damage. For more info on Crohn's and ulcerative colitis, be sure to tune in to our IBD sketch, airing Saturday mornings. Check your local listings.